ಹೇಗಿದೆ ಗುರು?
Hi, I'm Dr. Manjunath, practicing pediatrician and allergy specialist in Bangalore. Today, among us, we have a prolific personality, a phenomenal teacher, and he happens to be none other than Dr. Gnanamurthy. Just not that, he happens to be one of the greatest human beings I've ever come across. Just listen to him. You will be mesmerized by his knowledge, skill, and his humanness. Stay tuned.
Hi, I'm Dr. Gnanamurthy, consultant pediatrician practicing in Bangalore City for the last 68 to 38 years. I am confined to office practice, though initially I had practiced in the secondary level tertiary care, but now I'm more focused with my parents, my patrons, their children. In fact, I happen to be their foster parent. Now, I'm going to discuss a topic called as cough. The cough, just like a fever, many people ask, is fever a friend or a foe? Same way, it can be addressed. The question can be addressed on cough, is it a friend or a foe? But let me tell you, just like fever, cough is one of the symptom, manifestation of so many problems that arises in the respiratory system. It's a reflex mechanism coming as an expulsive expiratory phase. So, when I said cough is a reflex mechanism, whenever there is irritations or what you call stimulations, then cough start producing. In that, we have three phases are there. One is called as inspiratory phase. The second one is called as compressive phase, and the third one is called as expulsive phase. So, inspiratory phase starts with air which has been trapped in the alveolus start coming out from the airway, starting from the terminal bronchioles, low, smaller airways, medium airways, then the trachea, then through the larynx and pharynx. So it passes through a journey. In the inspiratory phase, the person, whenever there's a cough irritation is there, when he about to cough, this is how the process goes on. There, in the inspiratory phase, the person will take a deep breath in. Once he takes a deep breath in, he pauses, and then the epiglottis gets closed. Then there will be contractions of the muscles, all the muscles involved in the respiratory system. Once they start contracting, the air within the alveolus and the respiratory airway started getting compressed and get squeezed, and there is no further pressure, there is no further way for the air inside to go out. Then it expels out in a jet way through the glottis, producing a cough. This is a expulsive, and it runs in such a speed, almost 800 kilometers, a speed of a jet Boeing per hour. So in that rapid speed, it moves ahead. In the process, it tries to clear out all the irritations, chemicals, maybe origin, maybe dirty sputum, whatever the collections is there. It tries to expel it out. So, in nutshell, cough is a protective mechanism. So it is a friend. But how long you can go on with coughing? When the cough lasts more than 4 weeks, what you call as a chronic cough, that is the time the parents get annoyed, the patients get annoyed, and that's the time they start shopping from doctor to doctor. And it is very, very important to address this issue in a methodical way, stepwise, what is called as algorithmic approach, wherein we go for a detailed history, we go for a detailed clinical examinations, and then we try to identify what is called as pointers and also addresses what is called as red flag signs, wherein we need to work urgently. And also we take a help of laboratory to augment our diagnosis, and finally we make a diagnosis. So while addressing cough, there are three things we need to address. The objectives are there. That is, we need to find out or localize the origin of cough, that is anatomical localizations. And then second thing is we need to know the pathological nature or what is called physiopathological changes occurring, that we need to know. For that we need to have a background of science behind each particular disease. And finally we need to narrow down the the causative agent called as etiology, because our main purpose is to deroot the cause, etiology. So in this process, we can address the cough. Now, when I said talked about history, there are many armamentarium with us to address cough, the way it starts, the way it originates, and the way it progresses, and the way it responses, what time of the day it starts, what time of the day it gets relieved, and what are the triggering factor, what are the past backgrounds which been act like triggering factors, and then we also need to address what time of the day or night it starts. And second thing is, the other thing is, we need to address, is there any relieving factors also. So by taking the detailed history, we may, because each time when you take history, we should know why we are taking history. Are we getting any point to rule in or to rule out, to keep certain diseases away, to keep certain diseases in? So on the whole, we may get a few cases. Again, we need to further act on this cough history. Now, when I said armamentarium of the cough, we talked about the quality of the cough, we talked about the onset of the cough, we talked about the relieving factors, and then there is one particular factor, armamentarium, called as sound. The way cough sounds, we gives lot of clue for the clinicians. For that, either parents can make a audio video recording, and our doctors should be familiarized with each type of sound of the cough, how it produces. Say, for example, the cough coming from the lower airway within the lungs, say, for example, in the alveoli, or if there is any irritation in the interstitial tissue or in the alveolus, it is a weak type of cough. There will be weak, repetitive, multiple cough, which is not really explosive one. It's just like this. Or sometimes if there is a phlegm, like in the case of the pneumonia, when it's getting resolved, then there will be some separations will be there and some phlegm start coming out. That time it becomes a wet cough where you try to bring out the phlegm there, it gets a little bit intensified. So you bring it out after that. So that is in a case of a alveoli or interstitial tissue wherein you can get pneumonia, it could be pulmonary edema, it could be interstitial lung disease also. Then as it travels from the airway, starting from the terminal bronchioles to the lower bronchioles, upper up, we get different types of sound. Say, for example, in the smaller airway, say for classically a COPD is what you see in adult, where the smaller airway gets collapsed. Now, in that case, whenever they get cough, they have to overcome the collapsed smaller airway. So there, what they do is they take a deep breath and they cough violently. So this is the cough what you get in a case of COPDs, where to overcome the smaller collapse, they put pressure in bringing out the cough. At the same time, when you go higher up in the median airways, what you call it asthma, here the problem is asthma is a highly dynamic disease. Each time the cough nature sound varies. To start with, if suppose if you have a cough variant asthma, it may come once in a way, you just may have a single bout of cough. So you have to imagine that you're coughing from the chest. So this is one thing. And second thing, as the war day goes on, it becomes more. So this is a type of what you get in a higher up asthma. As you travel, when you travel the trachea or when you travel the larynx or pharyngeal area, you get a loud sound, more of a barking type of cough or what you call a brassy cough. It's a bit difficult to differentiate between brassy and a barking cough. The brassy cough gets where in a rigid pipe like trachea. The barking cough you get in a case of laryngeal area or pharyngeal area. There, it is a single episode. You take a deep breath. See, it's a metallic type of cough. And as it goes, in case of upper airway, like in adenoids or in the nasal area, where there will be constant dribbling of the phlegm, which goes backwards, and travels, and start irritating the pharynx. You get a cough, clearing cough. That yeah, as if no, if you're clearing the throat. This is type what you get in upper airway cough syndrome. Then there is in the same upper airway you get one more what is called as psychogenic cough, where the origin of cough is not in the respiratory tract, the origin of cough in the mind. It's in the mind. Earlier days it used to be called a psychogenic. Now we call it as a somatic disorder cough, where the cough comes purposely, repeatedly, stereotypically, and it comes in a bout of 1, 2, or 3, and it is a stereotype. Sometimes it may come in bouts of 1, 1 cough, or a 2, 2 cough, or a 3, 3 cough, and that gets more in the presence of caregivers. See, it goes on uncontrolled, no relevance for it. There is no difficulties, but child goes on coughing, and it gets vanished when there is no attention seeking or when in the night time. So this is about psychogenic cough. Then there is two more types of cough are there. When a small infant, what is called a staccato cough, which again a very small 3-month infant or less than 3 months, where it's difficult for the child to cough. Each time child has to breathe in and cough, breathe in and cough. So this is a type of called a staccato type of cough, usually getting chlamydial infection. Then you get what is called a pertussis cough, and thanks to all the immunization process, hardly we see this type of pertussis cough in these days, but in those days it used to be a common episode where a child get cough paroxysmally, spontaneously, and gets uncontrolled. It's a prolonged one, and patient has to take a deep breath after that because the cough continuously get exhausted. It starts like this. This is a type of cough in getting pertussis. So this way we make out different types of cough which acts as an armamentarium in making a diagnosis. So ladies and gentlemen, it is always important. As a doctors, we need to be aware of this, and as parents, if the cough is bothering, try to do video or audio recording and then show it to your doctor. At least this will give a clue. I had a child, almost a 3-year child, that suffered cough and been shown to various doctors. And I also did a lot of investigations I could not do. While doing one particular test called as FOT, child was coughing. I heard the type of cough. It was brassy, loud cough. Immediately the cough must be coming from somewhere in the vocal cord area or in the trachea area. It's a brassy type of cough, rigid cough. Then, since we could not do anything, when I got a bronchoscopy done, the child had tracheomalacia, and further we also found out there's some amount of compression happening. When we did a CT, it found to be TB, lymphadenopathy, and child was treated and child is doing well. So thank you, ladies and gentlemen. Though cough is a friend, it will be annoying. Please consult your doctor if the cough persists beyond 2 weeks. Thank you.